Hola, buenos días a todos y bienvenidos un viernes más a las sesiones científicas del Servicio de Cardiología. Yo soy el doctor Ignacio Ferreira, jefe de Servicio de Cardiología del Hospital Valle d'Hebron, y simplemente recordar que las sesiones se retransmiten online y que a pesar de ello, pues todos los asistentes tienen la oportunidad de hacer preguntas al ponente mediante un chat que hemos habilitado y cuyo número aparecerá repetidamente sobreimpreso en la pantalla durante toda la presentación. Ponente que tenemos hoy el lujo de tener a la doctora Magalí y cuya presentación correrá a cargo de la doctora Laura II. Cuando quieras, Laura.
Buenos días a todos. Efectivamente, la sesión de hoy versa sobre cardiopatías congénitas. Contamos con la presencia de la doctora Magalí del Hospital Georges Pompidou de París para hablarnos sobre las nuevas guías de práctica clínica de la Sociedad Europea de Cardiología sobre cardiopatías congénitas del adulto. Estas son unas guías que se han hecho esperar. Las previas datan de 10 años atrás. Y durante estos 10 años, aunque no ha habido grandes avances en el sentido de grandes estudios, ensayos clínicos randomizados, como podemos ver en otros tipos de guías, sí han pasado cosas importantes como para tener actualización en las guías. Como digo, no hay grandes estudios. El nivel de evidencia de estas guías, en la mayoría de los casos, son recomendaciones tipo C, consenso de expertos, porque, como digo, no hay estudios o ensayos clínicos randomizados que lo puedan avalar, como es normal en una población tan heterogénea como son las cardiopatías congénitas, y por eso precisamente es importante tener unas guías por consenso de los expertos que nos pueden orientar sobre cómo manejar nuestros pacientes. En este caso, como digo, tenemos el privilegio de contar con nosotros con la doctora Magalí. Ella es una de las coordinadoras de la revisión de estas guías de práctica clínica que nos han venido este año pasado. Ella hizo su formación en cardiopatías congénitas del adulto en hospitales Georges Pompidou y también en el Hospital Royal Brompton, y actualmente es el jefe de la unidad de cardiopatías congénitas del adulto del Hospital Georges Pompidou de París. Además, es una ponente habitual de los congresos internacionales de cardiopatías congénitas del adulto y de cardiología en embarazo, y es miembro del núcleo de la Sociedad Española Europea de Cardiología, y por tanto es un gran privilegio. Magalí, good morning.
Good morning.
I gave a brief introduction of your CV, and I just told that you are the best person to discuss the lecture.
I understood a little bit because I learned Spanish when I was at college.
Oh, great.
But thank you so much.
That's great. So to us, it's a great honor to have you here today. It's a great privilege, and I am very thankful because I am aware of your busy schedule. So if you found some minutes to give us this lecture, that's great for us. And I just give you the word to give us your view of these new guidelines on adult congenital heart disease from the ESC. Thank you very much, Magalí.
Thank you, Laura. Thank you for this kind introduction, and I'm very happy to share this with you today.
Could you share your screen again, please? Thank you.
Thank you. Thank you for this kind introduction. I'm very happy to be with you at this webinar, and as it was introduced, I will try to present you the new items of the 2020 ESC guidelines for adult congenital heart disease management. First of all, I would like to present you all the members of the task force who wrote on this document and evaluate this document. Many of them are from several European countries, and we have one colleague from Canada, Dr. Oshlin.
We are not seeing your screen. We are not seeing your screen.
Okay, sorry.
Just return here with us. Make a share screen again.
Mm-hmm.
Thank you. Yeah, now.
Okay, I'm sorry. I start again then, but quickly. With this slide. Okay. Then I would like to present you all the members of the task force who prepared this document, and most of them are from several European countries, and there is one colleague from Canada who is Dr. Oshlin. And the new in these guidelines is the modern approach of management of disease patients. And I will try to highlight in my presentation that disease patients are born with a CHD, but they have a lifelong chronic condition with several issues that should be managed with expertise at each point. I show you here remembers concerning the classification of the recommendation, and I think that most of you knows it is recommended format because it's very common with this type of documents. Normally, there is a first classification with class 1, which moves to class 3. According to the evidence or general agreement for treatment or procedure that is recommended or indicated in class 1 should be considered in class 2A or may be considered in class 2B or is not recommended when it's a class 3. And with this class of recommendation, there is levels of evidence with level of evidence A that concern data when the recommendation is supported by data derived from multiple randomized clinical trials or meta-analysis. Level of evidence B when there are data derived from at least a single randomized clinical trial or large non-randomized studies, and level of evidence C when they are from a consensus of opinion of the experts. Our recommendation, as it was introduced by Dr. Doss, are mainly supported by a level of evidence C. We have only one recommendation of level of evidence A, because we have very limited data from these large randomized controlled trials, including studies to evaluate drugs effect. Most of these trials excluded our patient with congenital heart disease, and it's a pity. We have 3 recommendations with level of evidence B, and the bunch of our recommendations are supported by a level of evidence C from a consensus of opinion of the experts, and small studies or retrospective studies and registries, which is very new compared to the previous ESC guidelines published 10 years ago. Is the naming of the cardiac disease, which is no more grown-up congenital heart disease, but adult congenital heart disease, because we are not dealing more with patients who are growing. We are less dealing with adolescents or young adults, but more with patients who moved toward middle age, and some of patients are older, with a very specific management and multidisciplinary approach. It's why we changed the name of the cardiac disease for ACHD. Also, in the same times, we changed the name of our working group at ESC. Before it was GOACH, ESC working group, and now it's ACHD, ESC working group. Also, this recommendation introduce classification of CHD complexity according the anatomical lesions. I'm not going to list all these different congenital heart disease because my presentation will be boring. But for example, we updated the classification for transposition of the great arteries. Usually they were considered as a severe cardiac lesion because most of our patient 10 years ago were palliated by a surgery called atrial switch, like Senning and Mustard, which leads with very high morbidity and mortality compared to the new management, which is now the arterial switch operation, meaning that we switch the great arteries. And according to this type of surgery, the patient is classified in moderate lesion when it's an arterial switch operation, and severe lesion when it's an atrial switch operation. And finally, which is the most important of these new guidelines, it's as I introduced at the beginning, it's the consideration of the lifelong chronic condition with several events throughout the circle of life, from birth with the diagnosis of CHD, but during the way the patient can undergo a new operation or new catheter intervention. He could be affected by atrial arrhythmia or sudden cardiac death. He can evaluate to heart failure, and these two complications are very frequent, very prevalent in this population. Also, the woman can have the desire of being pregnant, and you have all the management of pregnancy in congenital heart disease. We have not to forget that this population is aging, and more of our patients are affected by acquired coronary cardiac heart disease, like coronary artery disease or stroke, and we have to screen cardiovascular risk factors, and also we have to address the end of life of this patient with a chronic condition, and all diseases point in their long way of life should be addressed carefully and at a good time by a multidisciplinary approach. It's why these guidelines introduced the staff requirements for specialist ACHD centers to allow these comprehensive and complete assessment and management of disease patients. Obviously, this team should include adult or pediatric cardiologists with ACHD certification, but also ACHD imaging specialists in echocardiography and CT and CMR radiologists with expertise in ACHD, specialists in congenital interventional cardiologists, and there is more and more there is a bigger and bigger place for this in treatment in our patient with residual lesion. Also, it's important to have cardiac congenital surgeons with a large experience in operation of congenital defect, anesthesiologists with an experience and an expertise of anesthesiology of patients with CHD and specific conditions such as PEH or cyanosis, which may be difficult in the management of anesthesiology. Specialist nurses are very, very important in the coordination of the care of disease patients during the adult care, but also during the childhood care. Invasive electrophysiologists with expertise in ACHD is also more and more important to manage these patients who are affected by almost 25 to 55% of them. Doctors specialized in pulmonary vascular disease is also important because 10% of our patients at least are affected by pulmonary hypertension and pulmonary artery hypertension. Clinical geneticists are also very important, and it is introduced in these new guidelines. And also with a very important part of the staff is a psychologist and social worker, and more place for palliative care team. The document is split in two parts. The first part, which is more general, and the second part addressing specific lesions. The first part started with the diagnostic workup with many recommendations concerning the different modality to evaluate the patient with a congenital disease and also to treat. In the diagnostic workup, you could have the part of echocardiography, CMR, CT, CPET, and cardiac catheterization with an importance where there is underscored the importance of risk of ionizing radiation. We have to consider the number of CT and catheterization in this patient to limit the risk of secondary cancer induced by abuse of ionizing radiation examination or treatment. Then we have to think about this. And also, which is very important, it's the introduction of biomarkers. Biomarkers, mainly neurohormones with BNP or NP-proBNP, are more and more important in the assessment of the CHD, less to make the diagnosis of heart failure, but more to determine the prognostic of the patient. And in this setting, it's important to perform several measurements of biomarker to situate, to put the patient in the course of his cardiac disease. It's also important to know that the level, the cutoff of the biomarkers to grade the severity of the patient case is varied according to the underlying CHD. Then we can compare a patient with a tetralogy of Fallot or a transposition of the level of biomarkers between a tetralogy of Fallot repair or a transposition of the great arteries. Then we have to keep it in mind and mainly perform several measurements of biomarkers when we follow these patients. So in this general part, there is a big part for therapeutic consideration, and the first therapeutic consideration concern arrhythmia, which is associated with high morbidity and mortality in adults with congenital heart disease. There is a list risk for different arrhythmias according to the CHD lesions and the recommendation list. I show you here the tables presenting all the different type of arrhythmia according to the underlying congenital heart disease, and you can see it's very specific to each cardiac defect. You can refer them in the document available on the ESC website, but also on the app, and you can move out the app to know what type of arrhythmia you can encounter in the CHD to make more accurate your diagnosis. This table is split in two parts because there is a lot of specific cardiac condition and cardiac lesion associated with the risk of supraventricular arrhythmia or ventricular arrhythmias, and also bradycardias, and it's split in sinus node dysfunction or atrioventricular block. For example, we know for that congenitally corrected transposition of the great arteries is associated with a high risk with complete heart block, and patient with transposition of the great arteries mediated by atrial switch are more often affected by the atrial arrhythmia or sinus node dysfunction. Then you can be this table is very helpful to situate to place your patient in the type of arrhythmia risk according the underlying cardiac lesion. Again, in therapeutic consideration concerning arrhythmia, there is a big place made to underscore the importance of understanding the cause, the mechanism, and the anatomy of the underlying CHD, because there is a great interaction between hemodynamic lesion and the risk of the mechanism of atrial arrhythmia. Then we always have to perform a multidisciplinary approach to know if we have to treat before or during the treatment of the lesion. We have we have to perform a concomitant arrhythmia treatment, mainly using early catheter ablation, and this again need a very good collaboration with a specialist in imaging with an expertise in ACHD, and also the EP doctor should have an experience in ACHD, and we enhance the place of catheter ablation in the management of atrial arrhythmia in this population, because we are dealing with young patients, and we know that the risk of recurrence is lower when we use catheter ablation rather than long-term medical treatment, which also is associated with a higher risk of side effects, like with amiodarone, the risk of thyroid disturb. And the fourth point, very important, concern a big entity in the congenital disease, which is tetralogy where targeting VT-related anatomical isthmuses in this congenital disease is very important to perform before implantation of pulmonary valve, even by whether it's percutaneous or surgical implant reintervention, because after putting this valve, the isthmuses may be no more accessible to make an ablation. That is very important to target VT before pulmonary valve replacement in tetralogy when there is an indication. Another part of this is therapeutic considerations concern antithrombotic treatment. And first important point is the use of Schatzvask and Hasbled scores in CHD, which can be used only in mild CHD, but no more in moderate or severe CHD, where the risk of thromboembolism is very high, maybe due, but not only due to this, maybe due to the risk of arrhythmia recurrence and evaluation to permanent atrial fibrillation with a higher risk of thromboembolism. Then Schatzvask and Hasbled only for mild CHD. I think it's a very big message in the use of antithrombotic treatment. This concern also a patient with a phantom circulation. However, in this population, in absence of atrial arrhythmia or previous thromboembolism, the benefit from anticoagulation versus antiaggregation is still new and clear, and we need more studies in adult palliated by phantom circulation. And finally, the guidelines introduce the possible use of NOAC, which are more and more introduced in the patient with atrial arrhythmia and on CHD. They seem to have similarly safe and effectiveness than VKA in absence of contraindication, including mechanical valves or severe mitral valve stenosis. But we still need more data, and I showed you a very recent publication from one of our member from the working group with Professor Diller from Germany, where you made a population-based study on medical administrative data from Germany and observed first an increased use of NOAC in adults with congenital heart disease. But you can see here that there is effectiveness and safety concerning thromboembolism and bleeding in ACHD, but we have less good results, and the hazard ratio was not for NOAC in CHD concerning the risk of major adverse cardiovascular events and death. Then we need more data, and we need more prospective data to define clearly the indication of NOAC in our patient. Another important issue, and that should be addressed in the management of our adult patient, is advanced care planning. When the ESC was published in August, in the same times, we were very lucky, and we can also use the publication on advanced care planning from the working group of ESC. And you see here that it's important to timely discuss the advanced care planning with patient with ACHD patient with patient-centered and comprehensive care. And we have more and more patients with heart failure, and the management of heart failure in very advanced heart failure can be very complicated and in this patient, and we have earlier as possible to address advanced care planning with our patient, and we can be helped by psychologists as well as palliative care team to address this issue. This document is very helpful and give very practical advice, and you can also read it on ESC website. And to finish, there are for this general part, there are additional consideration concerning pregnancy, anti-conception, and genetic counseling. The first part concerned the risk of pregnancy associated with congenital disease, and you find again the classification according to the underlying cardiac lesion and cardiac function of the woman. I show you here the class 3, the WHO class 3 and the WHO class 4, which concern women with a high risk of maternal mortality, of morbidity associated with pregnancy, and for WHO4, that very high risk of maternal mortality and severe morbidity. These recommendations are in accordance with the last ESC recommendation concerning the management of pregnancy in a patient with a cardiac disease. And as you can see in the list of WHO4, they recently introduced the place for Fontan with any complication, meaning that it's very selective in this setting, but also systemic RV with moderate or severe decreased ventricular function, and obviously patients with severe arterial aortic stenosis or mitral stenosis, and severe aortic dilatation or coarctation, and patients with pulmonary arterial hypertension. All disease patients should be recommended against pregnancy and should have an effective contraception. Then it's very important to discuss this point with our young woman, young patient, when we meet them after their transfer to adult care. Also, we stay in pregnancy, and the recommendation for the first time introduced the risk of recurrence associated with the congenital disease. We know that it's important to screen the risk of recurrence of congenital heart defect in the fetus during the second trimester. And here, according to the underlying parents' CHD, you have the rate of recurrence, which is different according to the fact that the patient is a woman or a man, then even men who want to become parent should be advised about the need of screening of fetus cardiac disease during the second trimester of their partner. And you can use this table to advise your patient and to correctly address the patient to the specialist to screen this recurrence risk. The second part, as I said at the beginning, is dedicated to specific lesions from moving from mild complexity lesion with mild complexity to a very complex lesion. And this starts with the shunt lesions. There are several new recommendations in this part or reviewed recommendation compared to the previous EAC guidelines on ACHD. The first one is the important place of invasive measurement of pulmonary vascular resistance in patients with a shunt lesion when there is a non-invasive sign of PAP elevation at echo, and also there are adjusted recommendations for shunt closure when there is a significant shunt, meaning a QPQS of above 1.5, according to calculated PVR. If PVR is less than 3 Wu units, there is no contraindication to close the ASD, VSD, or PDA when there is a significant shunt. But after this, we are in the gray zone. And when the PVR is between 3 to 5 Wood units, the closure can still be considered, but we are in class 2A. And when the PVR is above 5 Wood units, there is a difference between the anatomy of the shunt. If it's a pretricuspid shunt, meaning a patient with ASD, there is a possible indication of ASD closure if there is a decrease of PVR under 5 unit Wood after targeted pH treatment and with use of fenestrated closure device only, then it's very specialized and it needs an evaluation and indication by a very expert team in CHD and PH. And when we are with a patient with VSD or PEDA, meaning patient with post-tricuspid shunt, the closure, if there is still a QPS or QS over above 1.5, should be carefully evaluated by the expert team only, and then we are in class 2B. After this, when we have, but if in this case, if the patient has cyanosis at effort with a VSD or PDA and PVR above 5 Wood units, there is a contraindication to close VSD and PDA. In ESD, when the PVR is over 5 Wood units, despite targeted pH treatment, we should not close the ESD. To help you, there are in the document as well as in the app several charts to help you to make the good decision about the therapeutic management or intervention in this patient. And I show you here the case for ventricular septal defect, where you have an algorithm according to there is a LV overload or when there is elevation of pulmonary arterial hypertension by echo, and and after this, according to pulmonary vascular resistance calculated by invasive measurement using FIC method, and according to the PVR, you can choose if it's possible or not to close the defect. This recommendation also underscored the more and more the use of interventional procedure to treat residual lesion, even in ventricular septal defect, with a recommendation when the VSD is a muscular ventricular septal defect, easily accessible for percutaneous closure of VSD by expert in catheterization in CHD. Other specific lesions concern aortic disease, and I start here with the aortic recoarctation. The recommendation introduce the importance of invasive confirmation of pressure gradient. It's not only a clinical gradient, and even if there is no clinical gradient, you have to check invasive pressure gradient to indicate aortic coarctation treatment. Then it's more accurate than previous ESC guidelines. Here again, they insist in the preference for catheter treatment, stenting in adults with coarctation or recoarctation, and also to consider intervention even in normotensive patients with increased invasive gradients, because in these patients, the chronic high afterload can lead to late cardiac complications such as heart failure or arrhythmia, but also increase the risk of cardiovascular complications such as stroke or hypertension, with the cardiovascular risk associated with hypertension. And we have always to remember that we are dealing with young patients with a long time course, and then we have to treat this lesion in case normotensive patients. Here again, you can find a chart to help you how to decide if the patient should be treated for recoarctation or not. Again, there is a big place for catheter treatment of significant recoarctation with a peak-to-peak gradient, invasive peak-to-peak above 20 millimeters of mercury. We introduce in patients with no hypertension the possible indication of coarctation stenting when there is significant narrowing of the aorta above 50% of the diameter. It's a class recommendation 2B, but it's new in our this recommendation. And also, which is important, it's the diagnosis of hypertension, and we are in accordance with the recommendation of hypertension from ESC, where the diagnosis should be performed by right arm ambulatory blood pressure. Then this should be more and more used in evaluation of patients with aortic coarctation. We are still with aortic disease, and there is a big place for aortopathies in these new guidelines, with expanding Marfan syndrome to irritable thoracic aortic disease, including bicuspid aortic disease and Turner syndrome. Also, the new guidelines include specific genes as risk factors, including Ehlers-Danlos disease, with a cutoff for aortic root replacement, preventive aortic root replacement, when aortic root diameter is over 45 millimeters. And the recommendations insist in the valve-sparing aortic root replacement as a procedure of choice to treat surgically treat these patients. Small new in Epstein anomaly concerned the surgical repair that should be performed by a congenital surgeon with a particular experience in Epstein surgery, because this surgery is very tricky. and needs an experience to perform as when it's possible a plastid, and you have a very comprehensive evaluation of the valvular disease using several modalities, but also a big experience of the surgery in this type of procedure. It's similar for atrioventricular septal defect. The guidelines newly introduced the importance that this surgery should be performed by a congenital cardiac surgeon, but not by a general cardiac surgeon. And in specific lesions, the big part, which is also the case in our population, concern patients affected by RVOT dysfunction, including RVOT obstruction and tetralogy of Fallot. There are adjustments in our new recommendation concerning thresholds for intervention according to requirement for surgical intervention, where the thresholds are higher compared to previous and more specified comparing to previous ESC guidelines. When there is a RVOT obstruction and there is an indication to treat this lesion only by surgical intervention and not by catheter intervention. In this part, there is a big place for pulmonary venous implantation, valve implantation. Then it's a big place for catheter intervention concerning pulmonary valve replacement when there is a non-native RVOT, meaning that there is a conduit or a biprosthesis, a biological prosthesis, but not a native RVOT. Also, the recommendation introduced RV volume thresholds to indicate pulmonary valve replacement in case of severe pulmonary valve regurgitation, and also the new recommendation had guidelines concerning arrhythmia management in tetralogy of Fallot, with a place for VT ablation in a very specific setting when there is a very only one type of VT when there is EP exploration, and if there is no additional risk factors, meaning that there is no risk for recurrence VT and the risk of sudden death in the patient with a tetralogy of Fallot repair. And also there is adjustment for indication of ICD in tetralogy of Fallot for primary prevention. You can find in the document nice figures who explain all the possible complication in each CHD lesions, its specific CHD lesion. Here I show you the complication that could be that could occur in a patient with a Fallot repair. As you can see, we have frequently a chronic severe pulmonary regurgitation leading to severe RV dilatation and RV dysfunction, and then tricuspid regurgitation. There is consequently higher risk of atrial arrhythmia, even atrial fibrillation from the left side, not only from the right side. Then it's very important to understand the mechanism. And I said at the beginning of my presentation, there is scare in the VSD and the RVOT. Then there is a higher risk of sudden cardiac death and ventricular arrhythmia. And finally, we have not to forget the LV, because there is a higher rate of LV dysfunction in tetralogy of Fallot, maybe due to interdependence between the both ventricle, but also there is sometimes coronary lesion, sometimes anatomic coronary anatomy, or previous history of problems with cardioprotection during the cardiopulmonary bypass during infancy. Then it's very important to have a comprehensive evaluation of tetralogy of Fallot to decide the optimal treatment, and with a multidisciplinary approach concerning evaluation and management. More complex lesions were treated, such as transposition of the great arteries. Maybe, as you know, transposition of the great arteries was earlier treated by when it's complete transposition of great arteries, meaning that there is right at the aorta that arises from the right ventricle, and the pulmonary artery arises from the left ventricle. Earlier, the surgery was palliative, meaning that it's the venous return that was switched to the good ventricle. It's the surgery called sealing or mustard, and consequently the right ventricle was let under the aorta and exposed to a chronic systemic pressure. These patients evaluate to RV dysfunction and then severe heart failure. Then the recommendation adjusted the threshold to define low ejection fraction when the ejection fraction is under 40%. They also downgrade the level of recommendation for tricuspid valve intervention in symptomatic patients from level recommendation class 1 to class 2B, because tricuspid regurgitation in this setting is frequently secondary to RV dysfunction, and it's more rarely due to abnormality of the valves, which can be corrected by tricuspid valve replacement or tricuspid valve repair. The new strategy to treat babies born with complete transposition of the great arteries since the 80s is to perform an arterial switch, meaning that there is a switch of the great vessels with a transfer of coronary arteries. And in this setting, their guidelines introduce the need of stenting pulmonary arterial branches when there is more than 50 millimeters of mercury of gradient through the stenosis in the right ventricle. If the pressure in the right ventricle is above 50 millimeters of mercury. And finally, the second part of transposition of the great arteries concern congenitally corrected transposition of the great arteries, also called double discordance. In this cardiac lesion, there is a high rate of complete outblock and this risk increased with aging of patient. And when there is an indication of ventricular pacing, and we think that the pacing will last more for 40% of time, the indication should be firstly for biventricular pacing and not only left ventricle pacing. And I finish with the most complex congenital disease, which concern patients with single ventricle palliated by phantom operation. Previous ESC guidelines did not put a recommendation to manage this congenital disease, and it's very new in the 2020 ESC guidelines for ACHD. This is necessary because these patients are more and more arriving in adult population, and we have more and more to deal with these severe patients. First, in this recommendation, patient with phantom operation who experience sustained atrial arrhythmia should be managed in emergency, because atrial arrhythmia may be badly tolerated due to a poor hemodynamic induced by atrial arrhythmia. And then the patient should be hospitalized and promptly treated with electrical cardiovation. When there is also, as I said in the general part, a place for anticoagulation. when the patient had experienced an atrial arrhythmia, but also when there is a past history of atrial thrombus or embolism, or a thromboembolic event, as I said. There is also specificity concerning the risk of pregnancy, and I discussed this point in the general part. Women with Fontan who want to be pregnant should have no additional complication, no previous atrial arrhythmia, no cyanosis. It should be a perfect Fontan. There is an important place for cardiac catheterization in evaluation of disease patient, and this should be by specialist cardiologist in ACH with an experience in catheterization in CHD or ACHD. Because these patients are very difficult to assess, and it's very difficult to diagnose the failing Fontan, the start of the failing Fontan, then the recommendation for cardiac catheterization is larger than usually, and is recommended when there is a unexplained edema or exercise deterioration or new onset arrhythmia or cyanosis or hemoptysis. All these signs should lead to cardiac catheterization evaluation. Also, as it was enhanced, atrial arrhythmia is a big problem in this patient, and there is a place for electrophysiologist evaluation and ablation with an important experience in this kind of complex patient with complex anatomy. Then it can be possible, and again, the need for multidisciplinary approach with a work with a cardiologist expert in ACHD and radiologist expert in ACHD evaluation is required. Regular liver imaging is very important due to the chronic pressure in the Fontan. There is a chronic pressure in the hepatic circulation, with a risk of cancer in very severe elevated liver disease. Then a collaboration with a hepatic hepatologist is very important, and you should make a comprehensive evaluation with hepatologist of liver function using imaging and biologic measurements, but mainly imaging with computed tomography or magnetic resonance imaging. It's a less strong class of recommendation, but treatment by endothelin receptor antagonist and phosphodiesterase 5 inhibitors may be used in this population to reduce pulmonary vascular resistance and maybe improve Fontan circulation, even if there is no there is still a debate and different results in a small randomized controlled trial. And in patient with fenestration in the Fontan circulation, because when there is when the surgeon performs the Fontan palliation or total cavopulmonary connection, so often the surgeon lets a communication between the atrium and the Fontan conduit, the TCPC. Then this fenestration is led to allow a pop-off in case of increase of pressure in the Fontan circulation. It's very useful to avoid chronic right side congestion, but sometimes patient does not need this fenestration. He is completely he has a good oxygen saturation, no cyanosis, and in this case, closure of the fenestration can be considered, but this should be carefully considered with a very expert team. To finish this presentation, I show you again this figure that summarizes very clearly the course of the patient with congenital disease from birth to end of life, with a very and it's a aging population, and we have more and more elderly patients with sometimes geriatric issues. Then it's important to have this multidisciplinary approach and specialized approach. Then it is recommended that all ACHD patients are seen at least once in a ACHD expert center to determine the most appropriate level of care, if the patient can be followed by a general cardiologist, or alternatively with the specialized cardiologist and the general cardiologist, or exclusively by the specialist cardiologist, like I show you with the last lesion with concerning patients with a single ventricles. Also, conditions that require expert medical attention in all ACHD patients and need consultation with the specialized in ACHD care concern the onset of heart failure in disease patients, but also arrhythmia, to have this multidisciplinary approach, not only EP approach. Also, when the patient have pulmonary hypertension, it's very important to have a comprehensive and expert evaluation of this patient, because this condition is very severe and very bad prognostic in disease patients. Cyanosis need expert evaluation by ACHD doctor. Pregnancy should be also, the desire of pregnancy should be anticipated, and evaluation before pregnancy and during pregnancy by expert is mandatory. And finally, patients with infective endocarditis should be referred to ACHD specialists to know the optimal management in this patient, and if there is a surgery, that this surgery is performed by congenital cardiac surgeons. Finally, I think you will see that lesions vary widely in complexity, and patients require an individualized and often multidisciplinary approach. For example, a patient with a tetralogy of Fallot sometimes can be not compared with another patient with the same lesion, because one of them can have a severe pulmonary regurgitation and the other one have a severe RV aortic obstruction. Then all these lesions are not comparable, and we have to carefully evaluate each of them. And finally, I would like to thank firstly the chairman and the chairman and chairwoman of the ERC guidelines of ACHD, who are Julie De Backer and Helmut Baumgartner, all the task force members who prepared and wrote the document. My co-review coordinators have been Hertz, and above all, the reviewers who put very, very nice comment and revision of this document, including Dr. Loss, who contribute actively in the revision of this document, and the ESC team was very helpful in the production of this document. Thank you.
So, thank you so much, Magali. It has been really a great overview of a very complex European guideline. But anyway, this catch-up has been welcome for everyone. It has been great. Just, I only have two questions. As a big picture, it's clear that this is a very complex disease as a whole. And this is expressed by the level of the degree of evidence is rather poor. See evidence for most of the diseases. So I would like to know if there is any initiative from the ESC to increase as a strategy to increase the level of evidence. I mean, I'm thinking about network co-working between several European centers to increase the number of patients in registry, potential clinical trials, and so on. And in connection with it, given that the management and the care of these patients is rather complex and only a few centers are capable to deal with it, what do you think that should be the role of the European referent networks for this adult population with congenital heart disease? Thank you.
Okay. For your first question, it's very difficult to improve the level of evidence. As you see, there is several different lesions with small populations. The event, because we improve the management of these patients, the events are very rare. Then we need, for example, we try to make a randomized control trial of valsartan in transposition of the great arteries. It was performed, it's true that it was performed only in one country. It was a national trials performed in Netherlands. They could include only 88 patients. They did not reach the estimated sample. Then it was underpowered. There are drop-off and loss of follow-up, and the trials was negative. Then it was after 3 years of follow-up, because there was not enough even. Then there are several issues to perform a trials, and because trials is the gold standard for a level of evidence A, and there are several issues. And I think you're right. Maybe with the big European network, but it needs a lot of money, and it's always a problems with drugs, trials drugs, maybe we could design this kind of trials. I think that, for example, I was very interested to know if we can perform a trials on NOAC in ACHD, because after the publication from the German group, we the indication of NOAC for preventive thromboembolism in atrial arrhythmia can be discussed, but we still have to be supported by the industry, and it's not the case, because we are always excluded from big trials. From, for example, from sacubitril trials, there are no ACHD patients. It's very complicated to do it, but maybe we have a big role, and a role stronger and stronger with industry and with ESC support to do it. And the second question, I think that France is very similar than Spain in the organization of care, and I'm very concerned by your question. I think that ESC probably, but maybe we will discuss this with Laura later. Laura Dos. I think that we should train our young cardiologists in ACHD more. I don't know how it is in Spain, but in France, the training in ACHD is very limited. It's, I think, maybe 10 hours. It's not an obligation to have a practical training in a specialized center, mainly because most of our centers are pediatric cardiology, they have pediatric cardiology department, not ACHD department dedicated to ACHD care. But I think that we have to better improve the training of our patients, to find place to train them, to see patients, to discuss cases, to make lectures. We can improve at our level of cardiology, but I think that the first is in the young cardiologist. I don't know what's your opinion, but
so I mean, I understand you will focus on the training of young cardiologists. I would say, I don't know, Later, Dr. Dos will illustrate us about the training of the young cardiologists in this area. But I am curious only because you mentioned about the guidelines that, for instance, early catheter ablation should be recommended, and the first option in those experience centers. So, can you illustrate about what experience centers mean, or if ESC considers some parameters or general figures about what a center can be considered experienced enough to perform catheter ablation in the patients?
Yeah, and you mean for catheter ablation?
Yeah.
It's
as an example of the.
Yes. It's not very clear. There is a paper from the ESC with one. I think the first author was a Spanish. I don't remember her name, but it's true that normally to have the experience, you should be in a center with the staff as defined in the recommendation. It's it's very important. You should have ACHD doctors and people with experience, even if they have not a heavy train in ACHD, but with experience in imaging ACHD with EP in ACHD. You need it. I think it's at least that. I don't know. I think it's the same than in France, but it's true. For example, for tetralogy most of EP doctors without experience in ACHD think that they could make an ablation of them. But actually, it's not completely the case, because you have to evaluate the pulmonary regurgitation and the impact of the heart, and you need to have this staff with all experts to evaluate the patient. I think this is required, and only high volumes center with who see a lot of patients with ACHD with CHD lesions can have this experience. I think so, but we need to share with other specialists, because we are not enough autistic patients. It's evidence.
Maybe this is the point. So thank you very much, Magali, for your excellent presentations. And now I give the word to Dr. Dos. Laura.
Hi, thank you very much, Magali. Thank you very much for this great overview of these complex guidelines. I maybe have two questions. I will start with the one that I'm interested in most, because I'm not sure if we are short of time to make the two questions. Nacho will tell us. Drafting a European guideline, to me, it sounds like a big process. Mainly this type of guidelines, when there is no high level of evidence, everything is mainly expert consensus. My question is how difficult is to reach a consensus, and in certain points. I mean, to your knowledge, for what you can recall, which have been the most controversial topics in which reaching a consensus has been more difficult in these guidelines?
It was funny because I did 2 rounds of reviews with reviews from 173 different reviewers. And there are only details in controversial details. It's more which word we use, which level of recommendation we put, because in respect with the format of recommendation, but there was no big controversy in how we have to manage lesions, except maybe for aortic stenosis, because we should be in accordance with the previous valvular heart disease ESC guidelines. And but the ESC team checked this. We have to not overlap over guidelines, and also if we refer to them, to be accordance. And concerning the subaortic stenosis, there was a little debate about when we have to indicate an intervention, but it was not a very important discussion, but also which was mostly reported. It's the definition of PEH, because we have two definitions. Firstly, it was the recommendation defined pulmonary hypertension with a mean pulmonary pressure over 25 millimeters of mercury, but many of people from the reviewer and maybe from reviewers are from the PEH group of ESC with a very important PH expertise. And they told us to change this definition with the recent NICE definition, and we reduced the level of definition of pulmonary hypertension to 21 millimeters of mercury, and we justify in the document why we did it, and with a table clearly defining the definition of pulmonary arterial hypertension. I think it is very important to have the same discourse, the same definition everywhere, to homogenize at least the diagnosis and after the treatment, but still we are in level of evidence C and recommendation. The mean of recommendation is to be evaluate and to evaluate. And if there is new management, it's always interesting to have a feedback on this and to update the future recommendations.
Thank you. And if I have time, I will make you another question. It's regarding the threshold for pulmonary vascular resistance.
Only 2 minutes, Laura.
Okay, great. The threshold of pulmonary vascular resistance for the closure of pre-tricuspid and post-tricuspid shunts. Mm-hmm. I see that in ASDs, it's very clear above 5 Wood units, you wouldn't close the defect unless you can lower that with treatment and that stuff. But in post-tricuspid shunts, there is no upper level for closure. It just leaves the issue to X%. Yeah. How is your input on that?
Me, I was a little bit. It was for me very difficult when I saw the reviewers. It was put in the first version of the document, and after revision, it was a little bit commented, but not changed. It's true that when it should be performed by very, very specialized center in PH. I think if you have only you are not a reference center, the most important one in your country, you should not decide. I think like in France, you organize national meeting about this very rare care. Us, we are doing it. And I think it's a good way to share this in national part and maybe sometimes between countries. It's interesting too. But I think that patients with PVR above 5 and with significant shunt without cyanosis maybe can be discussed to close the shunt, and probably with PH treatment too. But we have no long-term results. And when we have the discussion in my staff, many people say, yes, okay, but in 10 years, your patient will have severe PH and you will regret to have decided this. It's still in debate, and I'm a little bit not comfortable with this recommendation because I think there is not enough data to support it, even the actual level. I don't know your thinking about this, but me, it's my opinion.
Mm-hmm.
I don't know what you think.
Those are very, very, very rare cases. Those with post-tricuspid shunts that are adult and they are still with a high QPQS and no,
they are very rare.
Wenger situation. It's a very rare situation. So
yeah.
I stop here. I not just already.
No, we don't have time. Unfortunately, we have to live here. But anyway, thank you very much. It has been really a pleasure, Magali. It has been great to have you here with this great lecture about congenital heart disease in the adult population, a very complex issue, and it's very clear that our young cardiologists will be well served with this lecture. Thank you very much.
Thank you.
Goodbye.
Bye.
Bye. Y para el resto, simplemente recordar a todos los oyentes que seguimos con las sesiones de los viernes, del próximo viernes 7 de mayo, con el doctor Michael Leitenauer, del Departamento de Medicina Interna de la Universidad de Salzburg, y que hablará de biomarcadores y enfermedad cardiovascular. Gracias y buen fin de semana.